So I'm going to talk about renal stones, hematuria, and then penile and scrotal conditions. Renal stones and hematuria on health pathways for urology are the two most accessed pathways. You guys look at them surprisingly a lot. I get a 3-monthly kind of overview of how often they're accessed. Kidney stones are increasing. They're a very common presentation for us. Unfortunately, my risk of that's higher than my wife's of getting one, particularly as I have a family history as well. But about 20% of us, which is a lot, will end up having a kidney stone sometime in their life. There's different types of stones. I'm going to skip through reasonably quickly because it's the end of the day, and the physiology of stones is probably not that interesting at 4 in the afternoon. But history, classically, it's really sudden onset pain, usually in the flank, can radiate to the groin. Often colicky, although not always. People just describe it as horrendous pain. They won't necessarily say it's colicky. They frequently have nausea and vomiting with it. They usually have a soft abdomen, although they can sometimes have quite a lot of inflammation around the kidney, which can make examination tender. So if the abdomen's tender, it doesn't mean that they don't have renal colic. And watch out for fever, particularly ask them about fever, because that's probably the biggest red flag for us. In terms of lab tests, I would do a white count. It's common for the white count to be mildly elevated due to that inflammation around the kidney. You'd often see white counts 14, 15, maybe even a little bit higher. Microscopic hematuria is usually present, although not always. So about 10% of patients with renal colic will have no hematuria at all. A midstream urine is really important because, again, if there was infection present, even if the patient didn't have fever, it would sort of raise our threshold for wanting to intervene. And a creatinine, again, is important. It's very common for the creatinine to be mildly elevated. They have one kidney that's obstructed, so not getting much function from that side. They've often had non-steroidals, which may affect their creatinine temporarily. And they're often dehydrated because they can't keep any fluid down. They've been vomiting. So it's very common for us to see, even in fit, healthy people, creatinines up around 130, 140, and we don't get too alarmed by that. If it's up, high 100s or 200, yeah, sure, that's different. Or if they've got background renal dysfunction, again, you would worry a bit more. For analgesia, Panadol is great. Non-steroidals should be the mainstay of analgesics for renal colic. As I said, they often have nausea and vomiting. So actually, rectal non-steroidals work really, really well and are very underutilized. There are randomized trials that show that they're as good as opiates. Sometimes opiates are necessary. Out in general practice, I don't imagine that you'd be giving too many opiates in your rooms. You'll probably refer them on if they're needing that degree of analgesia. Red flags in renal colic are really important. This helps to determine which patients you might think about managing in the community versus the ones you absolutely should be referring on at least to ED, if not through to urology. Any signs of sepsis, we want to see them early. Fit, healthy, young patients can go from being perfectly well to having profound sepsis and end up in ICU within 12 hours with this. That really can be very dramatic. So we have a very low threshold for accepting people into the service. If they have a solitary kidney or pre-existing renal function, their renal function is likely to deteriorate reasonably quickly. So again, they're likely to need early intervention. Obviously, if they're already in significant acute renal failure, we want to see them. And thinking about other diagnoses, the classic, particularly in the male over the age of 60, would be a AAA. We've had several patients sort of sent in with renal colic, and you get the scan back and there's, whoa, crikey, big panic. Ectopic pregnancies in young females, appendicitis, and in young men, testicular torsion would be the other sort of acute diagnoses that are important to try and differentiate from renal colic. Oops, I think I skipped one. Anyway, how do I go backwards? Anyone know? Well, I'll just talk about imaging anyway. CT-KUB is, who should be admitted? Yeah, there we go. Patients with red flags, obviously. And the other one is patients who have pain that can't be controlled adequately in the community with analgesia, as discussed. Everyone else can actually perfectly safely be managed in the community because most stones don't need intervention. CT-KUB is the best imaging. Has a really, really high sensitivity for stones. There are almost no stones that are missed on a CGKUB. It also gives us information accurately about where the stone is in the urinary tract, which helps us for treatment planning. And also you're getting three-dimensional imaging of the rest of the abdomen, so it helps pick up some of those other diagnoses. Ultrasound and KUB are sort of second best, but they will miss a lot of stones. Ultrasound, you're often looking for secondary signs like hydronephrosis rather than necessarily actually seeing the stone. KUB, a lot of stones are either too small, so you don't see them because there's not enough penetration on the X-ray, or they are radiolucent stones, which we'll talk a little bit about later. So as I said, most stones will pass on their own. So how do you decide which ones you might want to intervene on? We think in terms of patient factors and stone factors. For patient factors, there are things like their occupation. The airline pilots, we have to get out every minuscule piece of sand out of their kidney before they're allowed to fly again. Ethnicity might come into it, because the reason I put that up there is that our anecdotal experience is that particularly Asian men have very narrow ureters, and so you might sort of reduce the size of stone that you might consider an intervention for. Polynesian men and women seem to have very wide ureters and can pass stones that are surprisingly large. And us Europeans are sort of somewhere in the middle as an anecdotal thing. Patients' anxiety and pain tolerance comes into this. There are some people who have large stones that don't seem to have much pain at all. Some have very small stones and severe pain, and also the effect that that's going to have on their work if they're a self-employed builder or whatever, and need to get back to work, you may intervene a bit earlier. And as I said, red flags are really key. And then on the stone side, the size of the stone, where it is, and the type of stone make a difference for us. So the more proximal or closer to the kidney the stone is, and the larger it is, the less likely it is to pass. And just for, we'll have these up, I think you're going to put them up on your website anyway, but that's just really summarising that. Medical expulsive therapy means using alpha blockers, so doxazosin, terazosin, or tamsulosin, and this will increase the chances of a kidney stone passing. It's actually best to target the stones that are sort of 50-50 whether they might pass or not. So a little 2mm stone, you probably don't need to put them on an alpha blocker because it's going to fly through anyway. If it's a 15mm stone, it ain't going to go anywhere, so it's not going to help. But if they're in that sort of 4 to 8mm range, which is the kind of grey zone, I think alpha blocker is your first line treatment. It also helps to reduce analgesic use. There are other things you can use. Interestingly, there are some studies showing that sildenafil may help. If it doesn't, at least they'll have a good time while they're passing their stone. We've talked about that. Dissolution therapy, this is an option that you could trial out in the community or out in GP land. So these are for uric acid stones. Uric acid stones are ones that you can't see on an X-ray or on a CT scan. Sometimes the radiologist will report the density or Hounsfield units of the stone. If it's a low density stone, then it's almost certainly uric acid. Or if they've previously had stones sent for analysis, or if they come to you with a stone, you can send it to be analysed, and then you'll know definitively what it's made out of. Patients who are diabetic or have metabolic syndrome are much more likely to have uric acid stones than the general population. They're the commonest group. There are other groups that that may develop them. How do you do it? The aim is to alkalinise the urine. And so you can do that with, the simplest is with urol sachets. Actually, the best will be with a thing called potassium citrate, but in New Zealand it's only available as a liquid, which tastes hideous, and no one would actually stay on it for the 3 months that they need to. So in my practice, I use 2 urol sachets 3 times a day. I tell them to take it in a large glass of water for 2 reasons. One, it makes it a little bit more palatable, but the other is it means they're getting plenty of fluid, because that's the other aspect to this, is they need a fairly high fluid intake and output. And if they're compliant with it, which is the key, this will actually dissolve uric acid stones in 70 to 80%. We've even had full staghorn calculi, several centimetres in size, completely dissolved with this. Treatment options for stones, I'll just go over this pretty quickly. We can use ureteroscopy. This just means putting a thin telescope all the way up all the way up the ureter to the kidney. So we can treat stones anywhere along the urinary tract with this. We could pass a small laser fibre up the telescope, and that bottom slide's just showing the little blue things, the laser fibre, and that breaks the stone into like sand or dust to get rid of it. Or if the stone's small enough, we can put a basket around it and just pull it out. ESWL stands for extracorporeal shockwave lithotripsy, which is hard to say and even worse to spell. This is a machine that sits against the patient's flank, and it fires these things called shock waves, which are a little bit like ultrasound waves, focuses them in on the stone and fragments the stone into small bits, and then the bits need to come out in the urine. This is the least invasive. It's done as a day case, I guess in some ways the gentlest treatment, but there are some restrictions to who we can use it for. And then a thing called a PCNL. This means putting a tube directly through the skin in the flank into the kidney, stretching up a channel that we can put a telescope in and out, and breaking the stone into reasonably big bits that we just pull straight out. This is used for really big stones. It's much more invasive, and therefore the potential complications are higher. Asymptomatic renal stones, which is probably the commonest type actually that you're going to see in your practice. They have an ultrasound for some reason or a scan and you find a kidney stone. The prevalence of these is estimated to be up to 8 to 10%. And there have been trials looking at, well, what happens if you leave them alone? Small stones in general, not a lot happens. Large stones over 15 millimetres, most of them progress on to symptoms within 5 years. Because of that, we decided as a group in Auckland that we will use 10 millimetres as a threshold for seeing those patients in our clinics. And so that's the threshold that's being used, I think, across all 3 DHBs here now. My key management points here, as I say, CT-KEB is the best imaging. It is available through POAC, so you can access it in the community. Otherwise, if someone has severe acute renal colic, it's perfectly reasonable to send them into ED, and they will generally organise a CT and go from there. Non-steroidals are excellent analgesia. If they have a stone that's 7 millimetres or less, you get your POAC CT back and they've got a ureteric stone that's 5 or 6 millimetres, I would trial an alpha blocker. I give it to them for 2 weeks. If the stone doesn't pass in that time, that's the time I'd be thinking about considering an intervention. If a stone is tiny, particularly if it's distal, so near the bladder, they definitely don't need referral. I would follow them up just to make sure that all of their symptoms have gone. And it's important that they have no symptoms whatsoever. So even if they just have mild flank pain, I would repeat imaging, which could just be an ultrasound, which should show you hydronephrosis if the stone is still there. Because not every 3 or 4 millimetre stone passes. It's just that 95% of them do. And small asymptomatic renal stones don't need treatment or referral. Definitely look out for red flags. And as I say, acute admission if there are any red flags present, or if they have acute renal failure or a solitary kidney, or they have pain that cannot be controlled in the community. There's a new version of the renal colic pathway come out. There's just 2 things I wanted to highlight from that. One, we previously used to accept asymptomatic stones, I think, from about 7 or 8 millimetres in size. We've increased that to 10 millimetres. And the other one was the ureteric stones. On the previous version, we used to discharge stones that were 6 millimetres or less. We had an unfortunate incident of a patient who was discharged with a 4 millimetre stone that then presented with a non-functioning kidney 3 years later. So we've reduced the threshold for which we'll see them and follow up in clinic. But the ones that are smaller than 4 millimetres, we won't see them in clinic. We'll make a recommendation that they see you if they have any ongoing symptoms at all, and if they do have absolutely feel free to re-refer them. Yep, we understand that, and it's a balance of risk, because seeing every 2 or 3 millimetre stone back in our clinics clogs our clinics for other things that we're struggling to see anyway, versus the risk of that stone not passing and leading to an issue like that. So I take that on board, but it's just a balance between what you can get through in clinic and so on. I'm just going to skip past that, not that I don't think it's important, but hydration is the key to preventing stones.